Welcome. The first question that came in the exam was a 10-year-old boy is brought to the OPD with pain, redness, and swelling around the great toe. The serum uric acid levels was high. The mother also added that the son has a habit of biting lips and there is dystonia is there. Now, the biting lips, this is basically the child is having a habit to cut down its own organ, that is called as self-mutilation. The child is having a problem of self-mutilation. There is increase in the uric acid. The moment we see this thing and in a male patient, it is going towards Lesch-Nyhan syndrome. In the Lesch-Nyhan syndrome, basically it is a deficiency of HGPRTS. HGPRTS deficiency will lead to Lesch-Nyhan syndrome where there is going to be more uric acid. See where the HGPRTS come when we have discussed about the purine metabolism. In the purine metabolism, we have discussed about this enzyme HGPRTS. If there is deficiency, the child will have profound mental retardation. There is going to be self-mutilation, increase in the uric acid, dystonia will be there. And it is going to be X-linked recessive disorder, means it is going to affect the male child. So the answer was very much clear-cut. It is going to be the HGPRTS deficiency. If there is a partial deficiency of HGPRTS, that is called as Kelly-Segmiller syndrome. So here what they are asking is that which enzyme deficiency it is here. It is the HGPRTS deficiency that is there. The second question that was there was which of the following lipid storage has the maximum predilection towards the cherry red spot on the retinal examination. Now cherry red spot, it is seen in many conditions and we have used one mnemonic to remember that the cherry red spot. This is how the cherry red spot will look like. The cherry red spot, we have remembered TSH, SCG and NF. TSH, SCG, NF. TSH is the Tay-Sachs, then is the Sandoff, Hurler, CRAO, Gaucher, Niemann-Pick and Farber disease, not the Fabry, Farber disease. So they are asking that in which of the following we are going to have the cherry red spot. The mnemonic was TSH, SCG and Farber, not Fabry, Farber and NF, Niemann-Pick and Farber. So here the only one that is coming in this mnemonic is the Tay-Sachs. Gaucher doesn't have the cherry red spot, Krabbe doesn't have, Fabry doesn't have. In the Fabry, what you are going to see? The angiokeratomas. It's a very important MCQ. If you see the word angiokeratoma, then the answer is going to be Fabry. In Gaucher, what we are going to see? We are going to see the anemia. We are going to see the crumbled tissue paper appearance in the bone marrow examination. That is Gaucher. In the Tay-Sachs, we can see, yes, the Tay-Sachs will have the cherry red spot on the retina. Then the next question was, the conditions shown below will be treated by the supplementation of which of the following? It is a very classical MCQ asked so many times in your exam. This is the Castle necklace appearance. And Castle necklace appearance, it is seen in vitamin B3 deficiency. That is pellagra. How we are going to treat this condition? We need to give the vitamin B3 supplementation, that is called as the niacin. The active form is nicotinamide. So we are going to give the nicotinamide. Niacin or nicotinic acid, also called as the nicotinamide. Here we have written like this, the niacin, it is also called as nicotinamide. It is also called as nicotinamide, also called as nicotinic acid. And if there is a deficiency of niacin, we are going to have the Castle necklace appearance, diarrhea, dementia will be there. So this image has came in the exam. This is the screenshot of your notes which we have discussed in the video lecture. So they have asked that the Castle necklace appearance is there. What is the supplement that you are going to give? We are going to give the nicotinamide, right? Then which of the following is mediated by the CRISPR-Cas9 technology? See, the CRISPR is the technology by which we are going to do the gene editing. Means if you want to remove some part of the DNA or you want to insert some new sequence in the DNA, you use this technology. This is called as the CRISPR technology. By this, we are going to cut the DNA at one particular end and we are going to insert a new sequence there. That is called as the CRISPR technology, and for that, this entire thing is called as the gene editing. We are editing the DNA at the genetic levels. So, which of the following can be mediated by the CRISPR-Cas9 technology? We are doing the gene editing. The next question was, which of the following substance is used for the sample collection tube for the blood alcohol estimation? There are various methods by which we do the blood alcohol estimation, and one of the estimation that we are doing is We take the blood sample in a tube which is containing the sodium fluoride and the potassium dichromate. The potassium dichromate is there. Now, we are going to put the blood sample in this. The moment we are going to put the blood sample in this, the potassium dichromate is going to unite with the alcohol. And because of that, the alcohol molecules are going to unite with the potassium. So this dichromate means the chromium will become free. The moment the chromium will become free, it will lead to color change. The more the chromium, the more the color change will happen. So basically in the blood, how much amount of the alcohol is there, it is going to unite with the potassium dichromate, and in the potassium dichromate, it is going to unite with the potassium part. So the dichromate will become free, it will convert into chromium, and the chromium will lead to color change. The more the color change means there is more chromium, means there is more alcohol. So for the blood alcohol estimation, we are going to use the vial which is containing the potassium dichromate. The sodium fluoride is also there because we don't want the glycolysis to be happening there. We don't want any microbes to be growing there. We don't want the bacteria to grow there, because if the bacteria comes there, to grow the bacteria, they will require glucose. They will require to do glycolysis. And the bacteria can alter the level of alcohol, because the bacteria can produce more alcohol or they can consume the alcohol also. We don't want the bacteria to be growing in that sample. So we are going to put the sodium fluoride, so the glycolysis can't happen. The glucose or the bacteria can't proliferate in that area. The next was old man presented with the complaint of confusion, tingling sensation. He has revealed a history that he is using the polished rice. That is his main diet. Now, this is a very clear-cut hint that the moment they say polished rice has vitamin B1 deficiency. Vitamin B1 deficiency. And vitamin B1 deficiency can lead to beriberi. This patient is having the confusion, tingling sensation, means peripheral neuropathy he is having, because vitamin B1 deficiency will lead to beriberi, and in the beriberi there are two types, the dry and wet beriberi. So because they are saying that this patient is having the peripheral neuropathy confusion, means they are talking about dry beriberi. Sometimes even we can have a mixed beriberi also, where we have both the symptoms. Because the neurological symptoms are the dry beriberi, the cardiovascular symptoms are called as the wet beriberi, and if both the symptoms are there, it is called as a mixed beriberi. So what we have written and what we have discussed in the video lectures, that polished rice, those who are taking polished rice, they can have the vitamin B1 deficiency, and vitamin B1 deficiency can lead to beriberi. Vitamin B1 deficiency can lead to Wernicke's encephalopathy also. So this is what is happening here, that they have said vitamin B1 deficiency was there, that was leading to the peripheral neuropathy, means they are talking about dry beriberi. The answer is going to be B, beriberi. Which of the following manifestations are seen in vitamin A deficiency? In the vitamin A deficiency, we have discussed that vitamin A deficiency can lead to night blindness, can lead to dryness in the eye. When it comes to the dryness in the eye, there are several manifestations that will be there. The patient may develop the Bitot spot, that is the white foamy conjunctiva. The white foamy conjunctiva, there can be xerosis in the eye, there can be conjunctival xerosis, there can be corneal xerosis, and this conjunctival xerosis will represent as the white foamy conjunctiva, that is called as the Bitot spot. The other manifestation that can be there with the vitamin A deficiency, night blindness, Bitot spot, there can be risk of acne because it leads to follicular hyperkeratosis. The hair follicles will be filled with the keratin, so the patient can develop acne, even can develop phrenoderma. So that is also follicular hyperkeratosis. So they are asking that vitamin A deficiency is related with what? Vitamin A deficiency is related with Bitot spot. A 16-year-old patient presents with diarrhea and happens to have some rashes on sunlight exposure around the neck area, and basically the patient is having the pellagra like features for last 5 years, and we have discussed pellagra like features means there is vitamin B3 deficiency. And what are the pellagra like features? The patient will have diarrhea, this is the first symptom. Then the patient will have dermatitis, that is the Castle necklace appearance, and then the patient may develop dementia. Vitamin B3. What we have also discussed is that the tryptophan amino acid normally can convert into vitamin B3 in our body. So to make the vitamin B3, we require the tryptophan amino acid. Right now they are saying that this patient is having vitamin B3 deficiency. And what they additionally mention is that this patient is having high amino acid urea. the HIAA level is normal, but there is high amino acid urea is there. High amino acid urea means this tryptophan amino acid is actually going in the urine, because it will go in the urine. If it goes in the urine, the tryptophan will be available very less, so the vitamin B3 can't be made. And in which condition the tryptophan is lost in the urine? The tryptophan is lost in the urine in the Hartnup disease. What we have discussed in the lectures, it was like this. When the blood comes in the kidney, sometimes the tryptophan get filtered, but the tryptophan usually get absorbed via the solute channel 6A19. In some patients, the 6A19 is not working, so the tryptophan will ultimately be lost in the urine, and we will have tryptophan deficiency. And if there is a tryptophan deficiency will be there, the patient will have pellagra-like symptoms. It is called as Hartnup disease. To detect the tryptophan in the urine, we can do the Obermeyer test. So they are saying that this patient is having the pellagra-like symptom and there is more amino acid in the urine. It is clearly going towards the Hartnup disease. Why they have mentioned this normal HIAA level? See, HIAA level we discuss in the carcinoid. Now, what is meaning of carcinoid is, see, it is something like this. From the tryptophan, we can make vitamin B3, and from tryptophan, we can make serotonin also. And serotonin ultimately converts into 5-HIAA that comes in the urine. So sometimes what happens is, there is excess production of carcinoid happen, that is in the case of carcinoid. In the case of carcinoid, the serotonin production will increase. Because the serotonin production will increase, all the tryptophan will deviate towards this side so that they can make the serotonin. And because there is more serotonin, so there will be more 5-HIAA will be there. And since all the tryptophan will go towards that side, the vitamin B3 will not be made and the patient will have pellagra-like symptoms. So the pellagra-like features can also be seen in carcinoid. But how we are going to differentiate? See, Hartnup is also having the pellagra-like feature and carcinoid is also having the pellagra-like feature. How to differentiate? What is coming in the urine? If the tryptophan is coming in the urine, it is Hartnup. But if in the urine 5-hydroxyindole acetic acid is coming in the urine, it is carcinoid. And since they have mentioned in the MCQ that the 5-hydroxyindole acetic acid is normal, so the carcinoid is ruled out. So they have specifically mentioned that the amino acid is coming in the urine. So it is a very nicely framed question that was there. They were trying to confuse you between the carcinoid and the Hartnup disease. The next was the post-translation modification, which is common in the collagen synthesis, hemoglobin synthesis, and immunoglobulin synthesis. See, what happens in all of them? Basically, when we have discussed the collagen synthesis, I have told you that how the collagen is made is basically you have 3 chains of pre-pro collagen and you are going to do the aggregation of these 3 chains and we are going to make the pre-pro collagen and ultimately we are going to make the collagen. So basically, to make the collagen, we need to do the unit aggregation. In the hemoglobin, you know that there are 4 chains of protein, 2 alpha chains and 2 beta chains. That is why we are saying it is alpha 2, beta 2. So basically again there is the aggregation that is to be done. In the same way, to make the immunoglobulin also we have to aggregate the protein chains. So they are asking that which modification is common in all the proteins, all these 3 proteins. It is the subunit aggregation which is common in all these 3 proteins. Methylation, hydroxylation, it is not common. See, gene editing, it is not a post-translation modification. This is not at all post-translation modification, so this cannot be the answer. Hydroxylation, it is commonly seen in the collagen. It is commonly seen only in collagen. It's a collagen modification that is done with the help of vitamin C. Methylation, it is mostly a post-transcription modification. It's a post-transcription modification, not a post-translation modification. Do you remember in the post-transcription on the RNA, we do some modification and one of the modification we do is we put a cap on the RNA that is called as 7-methylguanosine. So basically we add the methyl group on the RNA on the 5' end, that is a methylation. That is a post-transcription modification, not the post-translation modification. So this cannot be the answer. This cannot be the answer. Gene editing is not at all any modification. So the answer is going to be subunit aggregation. The process that converts the unconjugated bilirubin into the conjugated bilirubin, or the unconjugated substance into the conjugated substance. See, when we have discussed the heme metabolism, what we have discussed? When the RBC is going to complete its lifespan, the RBC is going to break down, we are going to get hemoglobin. The hemoglobin is going to be further break down with the help of enzyme heme oxygenase, which is actually a microsomal enzyme. We are going to get biliverdin. The further breakdown will make the bilirubin, which is a water insoluble substance, and we want to throw it out. So to throw the substance out from the body, we need to convert it into water soluble substance. How we are going to convert this? This unconjugated bilirubin, now with the help of albumin, it will be transported all the way to the liver, and the liver will conjugate some substance on this so that it converts into the water soluble substance. This unconjugated will convert into the conjugated one. And how it is going to be done? We are going to use an enzyme that is called as the UDP glucouranosyl transferase. UDP glucouranosyl transferase, we are going to attach the glucouranosyl group. So they are asking that how to convert the unconjugated into conjugated. We need to do the glucouronidation. We are going to do the glucouronidation, that is going to convert the unconjugated into conjugated one. Which of the following is a cause of unconjugated hyperbilirubinemia? In which condition the unconjugated bilirubin will increase? See, we have discussed, just now we have discussed that to convert the unconjugated bilirubin into conjugated bilirubin, what we need to do is basically we need to do this reaction with the help of UDP glucouranosyl transferase. If by any chance, if this enzyme is not there, this reaction will not happen. If there is a deficiency of this enzyme, the reaction will not happen and the unconjugated bilirubin will increase. In which condition we don't have this enzyme? If there is a mild deficiency, that is called as the Gilbert syndrome. And if there is a severe deficiency, that is called as the Crigler-Najjar syndrome. So in the Gilbert and Crigler-Najjar, the unconjugated can't convert into conjugate, and the unconjugated bilirubin is going to increase. So they are asking that in which of the following condition the unconjugated bilirubin is going to increase? It is going to be the Gilbert syndrome. In the Dublin-Johnson and Rotar syndrome or the biliary atresia, we are going to have increase in the conjugated bilirubin. Here we are going to have the unconjugated bilirubin. I have also told you one mnemonic. Do you remember how to make the double roti? You take one roti, you take one more roti and you conjugate them. If you conjugate them, what you are going to make? You are going to make the double roti. So double roti is made by conjugation. The mnemonic is the conjugated bilirubin, it is going to increase in double roti. Double roti is related with the conjugated bilirubin. This is how we can remember it. Then a 3-day-old baby is presenting that he is unable to tolerate the breastfeed. There is a newborn which is unable to digest the breast milk. The mother is breastfeeding. The moment the mother is breastfeeding the child is having vomiting. The child is not able to tolerate the breastfeed, but the child is able to accept the normal glucose. When we are just giving the plain glucose solution, the child is accepting that. Means what is happening in this child is, see, the breast milk contains lactose. The lactose will go in the intestine with the help of enzyme lactase. It will split into two, glucose and galactose. The glucose and galactose will be absorbed and they will ultimately reach to liver. Right now my concern is galactose, so I am focusing on galactose. The galactose will reach in the liver and then it will be metabolized. To metabolize the galactose, it will convert into galactose 1-phosphate. Then it will convert into UDP galactose with the help of enzyme galactose 1-phosphate uridyl transferase. That is called as the GalPut. Galactose 1-phosphate uridyl transferase. Galactose phosphate uridyl transferase. If this enzyme is not there, this molecule is going to increase. And the problem is this molecule is going to be impermeable to the hepatocyte membrane. So it can't go out. It is going to accumulate in the liver. The liver will become big. Plus, because this reaction is not happening, the galactose is also going to increase, and this galactose small amount of galactose can directly come out, and this galactose can convert into calcitol, and ultimately it will lead to the oil drop cataract. There is increased risk of E. coli infection. The patient is going to have the low IQ also. There is going to be damage to the liver because this galactose 1-phosphate can't come out from the liver. So there is going to be damage to the liver. So the child will have jaundice. So what is happening in this patient is this baby is not able to tolerate the breast milk. This is a classical galactosemia. The breast milk followed by vomiting or unable to tolerate the breastfeed. It is classical galactosemia and it is due to deficiency of galactose 1-phosphate uridyl transferase. It is due to deficiency of galactose 1-phosphate uridyl transferase. Can you tell me aldolase B deficiency leads to what? Aldolase B deficiency lead to hereditary fructose intolerance. The child will not be able to tolerate the fructose. Phenylalanine hydroxylase deficiency will lead to phenylketonuria, where the child will have very bad smell in the urine. The mousy smell of the urine will be there. Glucose cerebroside deficiency, beta glucocerebrosidase deficiency, it will lead to Gaucher disease, where the patient is going to have the anemia. Right? So this is how we are going to make the diagnosis. The breast milk, the moment the breast milk is not tolerated, is going to be galactosemia. Zellweger syndrome is due to which of the following defect? See, what is Zellweger syndrome? When we have a very long chain fatty acid and we want to burn these fatty acid, normally where the burning of the fatty acid happens? In the mitochondria. But the very long chain fatty acid, they are unable to go inside the mitochondria. They will not be able to be transported. Because who transports the fatty acid? It is the cat. The cat is unable to transport the very long chain fatty acid inside the mitochondria. So these very long chain fatty acid will go inside the peroxisomes. And then the peroxisomal enzymes will convert this very long chain into small chains, so that the further metabolism can occur. If by any chance these peroxisomal enzymes, particularly the peroxines, if they are not working, if they are deficit, the very long chain fatty acid will come here, but it will not be metabolized and it is going to accumulate in the peroxisome. And this is called as Zellweger syndrome. So Zellweger syndrome, it is related with the peroxisomes. Zellweger syndrome is also called as cerebrohepatorenal syndrome. Means there is going to be damage to the brain, liver and kidney. Which enzyme is defective? Peroxines, which are found in the peroxisomes. It is called as cerebrohepatorenal syndrome. So they are asking, Zellweger syndrome is related with what? It is related with peroxisomes. What is the composition of the disaccharide lactulose? See, lactulose is a laxative. It is used for the treatment of constipation. Now, how the lactulose is made? Lactulose is a disaccharide. Lactulose is basically a combination of galactose plus fructose. So it was a very simple, straightforward question that was there. That what is the lactulose? Lactulose is galactose plus fructose. What is glucose plus galactose? It is lactose. Glucose plus fructose, it is going to be sucrose. This is lactulose. This is lactulose. And we don't have the glucose plus lactose. Nothing is like that. We don't have like this. So this was a dummy choice. The remaining three I have written, and lactulose, they have asked lactulose, it is made up of galactose plus fructose. The next is a 35-year-old patient is brought to the emergency room in a state of agitation, impaired judgment, and the patient is having a history of strenuous exercise but forget to take meal, and later he went into alcohol party. Now he is having this impaired judgment, agitation that is there. See, what happens is when we consume a lot of alcohol is going to produce a lot of NADH. And how this NADH will be produced? This NADH is basically produced like this. Because of alcohol, actually, the NAD will be converted into NADH. We are going to produce a lot of NADH because of alcohol. Those who consumes a lot of alcohol, they have a lot of NADH. Now, what is the problem with the NADH? We have discussed a process called as gluconeogenesis. When we don't take meal, still we don't go into hypoglycemia because we can do the gluconeogenesis. The product of gluconeogenesis is going to be glucose. Now, to do the gluconeogenesis, actually what we do is we require the NAD. We require the NAD so that we can do the gluconeogenesis. And how we are going to require the NAD is basically the gluconeogenesis is done by the several substances such as the pyruvate, the lactic acid, the glucogenic amino acid. Whenever we want to do gluconeogenesis, actually we require the NAD. But when someone consumes a lot of alcohol, all the NAD has converted into NADH. So the NAD will be very less. If the NAD is not there, the reaction can't happen and the glucose can't be formed. So after consuming the alcohol, there is a very high chance that the patient might develop the hypoglycemia. Why the alcohol patient develops hypoglycemia? Because they don't have the NAD molecules. If the NAD is not there, the gluconeogenesis can't happen in the liver. So they are saying that which of the following process is inhibited. So he is having these problems. He is unable to do the gluconeogenesis. A 7-year-old child presents with short stature. He is having some patches on the skin. Some learning problem, means mental retardation is also there. Workup revealed that he is having some defective DNA repair. due to double strand breaks. There are some double strand breaks are happening and is unable to repair. Which of the following is the most likely diagnosis? See, what we have discussed is like this. If there is a mismatch repair, means sometime normally what happens in the DNA, A should club with T and G should club with C. By any chance, if there is a mismatch, and that persists, that is called as the mismatch repair defect, the patient develops the colon cancer, HNPCC, or the Lynch syndrome. But if there is a double-stranded break and it is not repaired, normally the double-stranded break is repaired via the non-homologous repair or the homologous repair. If the homologous repair is not working, the patient will develop the Wermer syndrome or the Bloom syndrome. And if the non-homologous repair is not working, the patient will develop SCID. So what they have asked is, if the double-stranded break is not being repaired, what the patient will develop? The patient can develop SCID, Wermer and the Bloom syndrome. And since the only one option was given out of the three, and that was the Bloom syndrome, and the clinical picture is also supporting the Bloom syndrome, so the answer is going to be Bloom syndrome. They are saying that the double-stranded breaks are not repaired, then it is going towards the Bloom syndrome. There are three conditions that can happen, either SCID, Wermer or Bloom syndrome. Here, because only the Bloom syndrome is there. A 40-year-old female presents to us. She is having palmoplantar pigmentation. The X-ray is showing the intervertebral disc is calcified and the urine becomes dark on adding the Benedict reagent. So basically, this patient is having some joint pain. This is the main problem that is there, and the urine is becoming dark on adding the Benedict reagent. The moment you see the urine darkness with joint pain, the diagnosis that should come in your mind is alkaptonuria. Plus, in the alkaptonuria, we have increase in the melanin also, so the patient can have the pigmentation. See how we have discussed alkaptonuria. Normally, the tyrosine converts into 4-HPP, which converts into homogenetic acid, and this homogenetic acid could have been converted into MAA by the enzyme mallyl homogenetic acid oxidase. But if this enzyme is not there, the reaction will not happen. These molecules are going to accumulate. And since the tyrosine will be more, the more melanin, and that will lead to pigmentation. Plus, because there is more homogenetic acid, this more homogenetic acid can convert into benzoquinone acetate, and this benzoquinone acetate can deposit as a crystal in the joints and will lead to destruction of the cartilage. That will lead to joint pain. Plus, this benzoquinone acetate can come in the urine also, that will make the urine dark. So this patient is having darkening of the urine, there is joint pain, and there is more pigmentation that is happening because there is more melanin that is there. This is a very classical case of alkaptonuria, and for the treatment, and you see that the classical picture we have written here, darkening of urine, joint pain and palmoplantar pigmentation. For the treatment, we are going to give the NTBC, that is called as the nitisinone. So they are asking this question that what enzyme deficiency this patient is having. The patient is having alkaptonuria and it is due to deficiency of homogenetic acid oxidase, HGA oxidase, right? So this is all from the FMG July 24 recall, and you can see that all the questions were from the notes only. They were very much pretty forward, straightforward questions were there. There were 2-3 tricky questions were there that you have to, if your basics were strong, you could have easily solved that also. Wish you all the very best. Thank you.